Okay. Yeah. So let's see people that will be watching the recording will actually get the gist. Because those times that you guys were not hearing me, people that will be watching the recording will actually hear me, so they will see it. Okay.
72-year-old man is brought to the physician for the evaluation of severe nosebleeds and 2 episodes of bloody vomit over the past 40 minutes. He reports that he has had recurrent nosebleeds almost daily for the past 3 weeks. The nosebleeds last 30 to 40 minutes. He appears pale, his temperature is normal, pulse is normal, blood pressure is normal. The patient's upper body is elevated and his head tilted forward. The patient's nostrils are pinched for 15 minutes. Despite all measures, he continues to bleed. Examination of the nose with a speculum does not show an anterior bleeding source. Anterior and posterior nasal packing fails to provide sufficient bleeding control. Endoscopic ligation of which of the following is the most appropriate next step in the management.
What are we going for? Which one do you want to like this?
Oh,
If you have the
posterior
opportunity.
bleeds. This phenopalatine artery.
Yeah. So why are you picking Pseudopalatine?
He's bleeding from posterior. It's a posterior bleed
Sorry, Dr. Miriam, is it my
because the
network
speculum
or
examination revealed
because I could barely hear Dr.
The
Antonia?
no anterior bleed.
Dr. Antonia, your network is broken.
So
I'm not sure she can hear us.
That network
Hello,
is
Dr. Antonia.
yes, yes.
We couldn't hear you. Your network was breaking.
Oh no, I was saying that the patient has a posterior nasal bleed, so will I get this phenopalatine artery?
okay. That's good. So it is the Pseudopalatine that I'm going to go for because I've done everything. So it definitely means that since it's not showing an anterior bleeding source, it's definitely going to be a posterior bleeding source. So take care of the Pseudopalatine, the patient is going to be fine. So adenoidal hypertrophy just means there's enlargement of the adenoids, right? And one thing that makes them enlarge is when you have recurrent infections. Think about that. So, what are the ways the patient is going to present? Because the adenoid is more like the nasopharynx tonsil, the tonsils within the nasopharynx. So it means that the person is going to be having it difficult to breathe through the nose. So they will be breathing through the mouth. And when they want to speak, they have little nasal quality to the speech. So they will be talking as if the nose is operated like something like, hypronasal voice. And you notice they're going to have this adenoid fasciae. So adenoid fasciae occurs when you have alteration in the changes of the face and the teeth because of constant mouth breathing. So they are going to be having protrusion of the mouth, the protrusion of the upper teeth. There's going to be malalignment of the upper teeth. The face is going to be long and narrow. The nose that they are not using is going to be small. And they're going to have a thin upper lip. So I think I have it here. So once you are seeing all these things, long face, long lean face, open mouth, of course, they are breathing through the mouth. The mouth is constantly open. Short upper lips, thin nose ribs, short upper lip, mouth positioned or prominent upper teeth. Once you are seeing all those things, eye, heart, palate, that's in keeping with the adenoid fasciae, in someone that is constantly using the mouth to breathe. So, the same thing with the hand tonsillar hypertrophy. You don't separate them; they occur together most of the time. So, they're having problem with breathing, problem with feeding, dysphagia, and of course, sleep disorder breathing with obstructive sleep apnea. So because of the obstructive sleep apnea, you see them having excessive daytime somnolence, they fail to thrive, enuresis because of the stress. They have enuresis, poor school performance, and behavioral problems. So if this person is having just mouth breathing, this adenoid fasciae, rhinorrhea, and the postnasal drip. Nothing with sleep. You can just use your nasopharyngoscopy to visualize the hypertrophied adenoid tissue. You can also do a lateral chest X-ray, lateral X-ray of the neck to see the adenoids. The way you can remember this nasopharyngoscopy is that just know that the adenoids are what? The tonsil are the nasopharynx. So you have to do a nasopharyngoscopy to look at the nasopharynx so that you can see them. But if these individuals is present with sleep disorder breathing, in addition to all these phase problem, they are not having, choking, gasping, sensation, waking up from sleep and the likes, just order your polysomnography immediately. How do you treat them? So infection, they can have recurrent infection, so you might need to treat initial root supportive treatments like pain control, adequate fluid intake. And if you suspect that the person is having superimposed gas, you need to give your penicillin, right? Just use your center criteria to calculate if you need to how you need to evaluate for the step priority. So once you see all those things, you just know what to do. And patient with current infection, if they have like 7 episodes in the year before, or they have 5 2 years before, or 4 3 years before, you have to consider a tonsillectomy because that means they're having recurrent infection. Like the previous year they have 7, 2 years before they have 5, 3 years before they have 4. Just do a adenotonsillectomy and remove everything. So if they're also having features of obstructive sleep apnea, after you have done your polysomnography, you have to do adenectomy, tonsillectomy to remove it. So it's very simple. It's not very hard. Acute and chronic laryngitis, laryngitis is just talking about inflammation of the voice box, the larynx. And this can come from what I'm doing now, excessive talking, vocal abuse and strain, people that cough too much. Probably the person is on drug and the person is coughing chronically, they can have laryngitis. People with infection, the commonest cause, infections, upper respiratory tract infection. People that are smokers, they irritate the larynx. People with GERD can have laryngitis because the reflux can enter into the esophagus and from the esophagus into the larynx. So the chemical irritation can cause laryngitis. So how do they present? Just watch for the history of dysphonia, loss of voice, impairment of the quality of voice, hoarseness of voice, cough. Then depending on the cause, if it's infection, you can have fever, sore throats and the likes. So, but the voice changes is high yield. The hoarseness of voice, the dysphonia, the coughing, think about laryngitis. So if it's acute, it's going to be less than 3 weeks. If it's chronic, it's going to be more than 3 weeks. So I have something here. Key point for acute upper respiratory tract infection and acute onset of dysphonia without symptoms of airway compromise, suggestive of acute laryngitis. If you palpate the head and neck and you palpate the lymph nodes there, you find lymphadenopathy greater than 1 centimeter, you can think of malignancy. Sometimes you might need to do a nasopharyngoscopy to look at the vocal cords, to check if there's any polyps or nodules there, and to see if the vocal cords are actually moving. If there's a mass there, they will not move well. But if there's no mass there, they will move. Or if there's any edematous swelling, that could be pointers towards infection. So, how do you want to treat? Now, what you want to do is that if the person is the type that talks, shouts every time, just tell them to keep a low voice. It's not that they are going to be whispering, but they are the type that shout, because you have some people that they are naturally shouters, just shout everywhere. So you have to tell them, guy, don't shout too much so that you don't damage your larynx. If they are the smoking type, tell them you have to reduce smoking. You have to also place them on PPIs to reduce the flux that could irritate the larynx and treat the cough and the infection. So that's the way you go about it. And you hydrate them, very important. You hydrate them, very important. Then if there's flux, you give PPI. You can see that the management you don't have to be a genius to remember anything of this management. You don't. Very straightforward. Then nasopharyngeal reflux is also part of the cause of laryngitis. It's just when you have reflux of caustic gastric content into the laryngeal tissue. Usually comes from GERD, and it's very common in people that are obese, because people that are obese, you have like the increased abdominal pressure transmitting to the esophagus, and from there you can have reflux from the abdominal pressure, into the esophagus because of the increased abdominal pressure. So obesity, you need to treat it to prevent the laryngopharyngeal reflux. And you have to also tell them to be cautious of certain food that they eat. So if you are taking food that's rich in chocolate, spicy peppermint food, coffee, and all those things, they can chocolate, peppermint. I don't think coffee is there. Caffeine, yeah, is there. Alcohol, acidic food, yeah. So how would this person present? So one thing you should not forget is that they will have something in keeping with like laryngitis, because the cause of laryngitis. So voice changes, hoarseness, cough will be there. It will be there. Cough, the hoarseness of voice, it will be there. But another thing that will be there is what you call globus. You see, don't forget, once you check a question, you are seeing something that looks like globus, foreign body stuck in the throat, like they're having a sensation of foreign body stuck in the throat. Once they put that in the question, just have GERD or your laryngopharyngeal reflux at the back of your mind. Please don't forget that. Don't be destabilized. Don't think it's foreign body. It is actually your reflux that is causing it. So dysphonia, cough, globus, dysphagia, and constant throat clearing. Sometimes they can even have this, sour-like taste by the time they wake up in the morning. So dysphagia, throat clearing, the globus sensation, the cough, and the dysphonia is in keeping with nasopharyngeal reflux. It means gastric content is moving from the stomach into the esophagus and from the esophagus into the larynx. That's the way it works. Avoid this diet: caffeine, chocolate, peppermint, alcohol, acidic food. Avoid all these things. Avoid smoking. Smoking too can cause it. So you tell them they have to wait for at least 2 hours after eating before they exercise, and they have to wait for at least 3 hours after they eat before they sleep. Because if you lie down immediately, you sleep, you eat, there's reflux. If you exercise immediately, you eat, there's reflux. So stop smoking, wait for 2 hours after you exercise, before you exercise, wait for 3 hours after you've eaten, before you sleep. So then you give your acid suppression for people with the GERD, like proton inhibitors and H2 antagonists. You can see very straightforward cases, very, very straightforward. So the benign and the malignant laryngeal lesion, we have the vocal cord polyps, the vocal cord nodule, and the recurrent respiratory papillomatosis. I think this is like a good question they like asking now. So people are getting it from time to time. So the vocal cord polyps is just more like a gelatinous growth in the vocal cord at the junction between the anterior 1/3 and the posterior 2/3 of the vocal cord. So, think about things that can cause laryngitis. Are you shouting? Are you a singer? Teaching? Do you smoke? Irritants like GERD, smoking, overuse, strain of the vocal cords. And they are going to also have the hoarseness of voice, difficulty in breathing, sometimes in severe cases. And you need to do a laryngoscopy or a stroboscopy, to evaluate for the lesions. Laryngoscopy is going to be the best. It will give you like a direct visualization. And you can do a voice therapy. Just train the singers on how they will sing so that they don't exert too much pressure on their vocal cords. And sometimes you might need to go in to do a microsurgery to remove it. You actually have to remove for polyps. You must remove to exclude the line pathology. You must remove. For the nodule, you might not remove, but they are like the same thing. It's just that the nodule have a fibrous cap. The polyp is just gelatinous growth. So both of them will cause the same thing. Smoking, GERD, everything is like the risk factor for both of them. Hoarseness is the same thing. The same investigation. It's just that you just tell them to avoid the irritants, and sometimes you can inject steroids. It's not compulsory you remove, but if it's disturbing, you have to remove by microsurgery. But polyps, you have to remove compulsorily. For the recurrent papillomatosis, this is just like warts within the respiratory tract. It occurs in the adult and the juvenile form. So in juvenile form, it's very common in individuals less than 5 years, and it occurs during delivery through the birth canal. They can, aspirate the virus, the human papilloma virus, serotypes 6 and 11. Those are the commonly implicated viruses, and just see these warty growths that have like this raspberry shape or appearance in the throat. If you see it in an adult, it's coming from oral sex. It's actually with significant morbidity because you have to repeat the curettage, the laser ablation, whatever you are doing. Repeat it so many times, so it can be causing significant distress for the child because it's very stressful. And sometimes it can undergo remission by itself after some years. So for the juvenile form, the risk includes being a firstborn, vaginal delivery, and maternal age less than 20 years. Very common in child less than 5 years. While for the adult form, it's common in people that have multiple sexual partners and they have a high amount of oral sex. So the hoarseness of voice is the commonest presentation. Voice change, episodic choking, the foreign body sensation, the globus, and they can have coughing, dyspnea, wheezing, and stridor. So if you do your laryngoscopy, you are going to see your multiple raspberry swelling. So once you see this, know that is papillomatosis you are working with. So how do you treat? There's no cure, but you can do a micro debridement with your CO2 laser therapy to debulk it, and later you can wait for it to regress. You can also administer some antiviral agents like cidofovir, cyclovir, ribavirin to treat that. But if they have significant airway obstruction, you can put in a tracheostomy. But don't forget, this will be your last resort. You are not going to be picking this as the second option or the first option, last resort. So after you have given your debridement, like your laser, you have given your antiviral, you can also give your interferon therapy, can also work second line. And if all those things fail, you cannot do your tracheostomy. The patient is in severe distress. You can prevent by giving your HPV vaccination. That's how you can prevent it. Do you have any questions? I am so
Yes.
tired.
So for the vocal cord, the vocal polyp and the vocal nodule, vocal cord polyp and nodule,
Yeah.
kind of stems from laryngitis, because it seems like all those things that causes the laryngitis also cause them.
Yeah. Yes. Smoking.
So you can just say kind of a secret you may not, except only if needed.
Yeah.
The cord, right?
Yeah. So Dr. Antona, what's your question?
No, I just want to understand, because both of them seems to be the same thing, and the cause seems to be what causes laryngitis too.
Yes.
So my question is it right to say that is both of them are kind of sequelae to the laryngitis? Can you just?
I don't think I don't think it's like a sequel of laryngitis. It's just that they have common risk factors. They have like common risk factors. Yes. They have common risk factors.
But both of them can still cause the hoarseness of voice too. So how do you differentiate, like in the exam, are they going to give us the result of the laryngoscopy?
Yes, so they can tell you there's a gelatinous growth.
Okay.
Or they can tell you that there's a fibrous scar. So if it's a fibrous scar, you know that that's a nodule. Gelatinous growth, that's a polyp.
Okay.
Let us look at a question to corroborate that.
And then, sorry, for the papillomatosis, you said laser surgery?
Yeah, laser surgery to debulk. You can do like debulking surgery, laser therapy, just to debulk.
Okay.
Yeah, so let's trash this question out.
A 2-year-old boy is brought to the office by his mother because of a 2-week history of progressive hoarseness. During the past week, he has also had 2 episodes of cough and shortness of breath that resolve spontaneously. The mother is concerned that these episodes might be asthmatic crisis similar to the ones his grandmother has. He has no other history of serious illness and takes no medications. His his mother did not receive prenatal care but reports an uncomplicated vaginal delivery at 38 weeks gestation. She was treated for gonorrhea during the first trimester. The patient is not in acute distress. Vital signs are within normal limits. Physical examination shows no abnormalities. Laryngoscopy shows multiple polypoid growths distributed asymmetrically over the true and the false vocal cords. So the following is the most likely diagnosis:
Papillomatosis.
laryngeal papillomatosis.
Yeah, that's very, very easy. No, very easy. So I think we are good to go. We are all set.
Yeah, thank you so much.
Dr. Ijoma is not here. As Dr. Ijoma